One of the first things I did incorrectly here, I think, concerning for appendicitis presents in the emergency room, which is following indicated concerning ordering a CT of the abdomen and pelvis with contrast. My goal was obviously the IV contrast on this one, right? I could have made that more clear. It said CT of the pelvis with contrast. I don't care about the CT or not, but the problem is when I put them in the ER and I give them something as emergent as appendicitis, you might not care about the IV contrast concerns because if that perfs, they can cause harm. And so that puts you in a mindset of ER, why do I really care about this? So that's mistake number one on my part. So I have to change this to a family practice patient where you do care and then make it not emergent. Not appendicitis, but family practice and not emergent. That's my first error. What the goal of this was to get you guys to figure out which one of these is a contraindication to contrast, okay? And here was my intent with the distractors. So age of patient, right, that was distractor number one, was the intent of in the slide, you're concerned about over 75 years old, you're only 62. So did you pay attention to the age of the patient? Did you truly know that material, right? That was the first one there. History of hypotension. Now I put history, not current. The intent of doing history of hypotension was to try to make you believe like, hey, this patient isn't hypotensive now, so it's not that they're unstable now, but they've had hypotension in the past because hypertension on the slide is a concern because hypertension can lead to kidney issues, so you need to be concerned about their kidney function if it's a patient with hypertension. So I went the opposite of the slide. That's what that distractor was meant to mean. I'm going to be removing hypotension even with the history of just because, again, with the ER and history, it was just a little too convoluted in that aspect. Hyperkalemia, I just straight screwed up, right? Yes, for those of you that picked hyperkalemia can be indicative of further kidney damage, further kidney insufficiency, so you need to further evaluate that. That was literally meant as an electrolyte abnormality that wasn't even on the slide. It was meant to be a throwaway, and I didn't think deep enough to kind of go, you know what, third order, what does hyperkalemia mean, what could it mean in that aspect. So that one was meant to be a throwaway, but we're going to fix that. But that is that. For those of you that were thinking that with hyperkalemia, 100% right. If you have hyperkalemia, yes, you're going to redraw it first because most hyperkalemia is usually traumatic stick for the most part, so you are going to redraw it. But for those of you that had to think, you're like, yeah, I'm going to redraw it, but until I know that, I'm concerned about the kidneys is 100% correct thinking, right? Liver insufficiency. That was literally meant for people who didn't remember that it was kidney function and they knew it was due to an organ being insufficient that filters things. So insufficiency was the word I was biting on in the aspect of where if you just word associated and didn't understand, you'd be like, oh, I know it's an organ that's insufficient. But insufficiency, there it is, that must be it, I'm going to choose the liver. Because remember, contrast filters through the kidneys, it does not matter what their liver function is. Right? Liver function is not going to stop you from giving contrast. But kidney function will. Which brings me to well-controlled diabetes. Well-controlled was intended for you to go, to test the logic of like, if I have a diabetic, what are the two main things I'm worried about if I have a diabetic? A, their kidney function, but more importantly, B, the medications they're on. The medications are nephrotoxic. So if you have a patient that has well-controlled diabetes, the thought process I was trying to get you guys to is go, great, they're well-controlled. I can't just send them to a CT scanner with IV contrast just because they're well-controlled. I need to figure out why. Are you well-controlled from just diet and exercise, or are you on medications? And if you're on medications and you took them this morning, I can't give you the contrast. And the well-controlled was meant to go away from diabetes of word association. If I just put diabetes, it doesn't really test that next level thinking. Well-controlled is meant to make you go, oh, they're fine, they're well-controlled. But there's that extra layer of why are they well-controlled and are they on medicine? Because if they're on medicine, they got to stop that 48 hours prior to the scan so we don't harm the kidneys, right? But because of primarily the history of hypotension, the hyperkalemia, the way that it kind of performed, the stem is kind of wonky, which I admit now after kind of looking into it and diving into it, it kind of veers you guys all over the place. That's why everybody got credit back for it. So questions on that? Is kind of what my thinking was and why each answer was supposed to be wrong, but why it might not have been. Okay, so give me some grace on that. I'm truly not trying to trick you guys. I know I say that, and you see this, you're like, you're just trying to trick me. He said he wasn't. But we have to create new questions, and there's really no way to know how they perform until we deploy them, which is why typically we only have a couple that like we create from scratch on each exam. So if this happens, it's very easy to go, where are my errors, points back, and that's kind of how it works here a little bit. So I just wanted to kind of clear the air on that one and make sure you guys understand where I was coming from, what my intent was. All right, give me a second, and we will jump into that. All right, good morning, here we go, good night, I should say. Okay, so for block 2, I'm probably gonna stand more behind the podium as long as this screen is working, so I can do a lot more drawing and tracing, okay? Chest, a lot of stuff looks similar. If you studied the last block by memorizing pictures only and not focusing a lot on the pathophys and everything, you got by okay. If you study this block by only trying to learn what abnormalities are in the pictures, you will not be okay. I need you to study the pathophys. I need you to understand the pathophys, because as you're going to see, you guys are going to come to me after 3 or 4 lectures, you're going to be like, ah, this all looks the same. A lot of this is going to look the same. The idea is knowing what normal is, knowing your anatomy. We'll talk about that when we get to those things, because knowing what part of the anatomy is abnormal is what's going to help you lead to other conditions if you understand the pathophys, what makes the left ventricle large, what makes the left atrium large, all of that kind of stuff. And then looking at the patient vignette, do they have fever, do they not have fever? Almost everybody that's sick is going to have some type of shortness of breath or dyspnea or something along those lines, right? So that doesn't really add up. So what are the other little things that are going on with the patient? Do they have a murmur, do they not have a murmur? Where is the pain at? What does it feel like? And you'll see as we get into there. And those are going to be the things that are going to help distinguish the image from the different diagnoses. Okay? So start studying pathophys. You got to know what the pictures look like, but definitely pathophys. And we have 7 lectures, 8 lecture blocks, plenty of time to get through it. So if it looks like we're behind, don't worry about it. We're going to be just fine. And we'll get through it like we did last time. But let's press forward. So 11 hours based off of just the chest. And yes, 5 lectures of the chest, 2 lectures of the abdomen. No, that does not necessarily mean that 80% of the exam is going to be chest and 20% of the exam is going to be abdomen. It's just there's a lot more going on in the chest, right? So make sure you know it equally in that aspect. Introduction, really this lecture is mostly about looking at it, understanding your anatomy, and going from there. What are we going to cover? Indications for plain radiograph. We're going to look at cardiac and pulmonary pathology, how images are produced, what's adequate, how do we tell the difference between posterior and anterior ribs, because you can, and that's important, right? What are the blind spots? How do we go through it? We had a systematic process for our MSK stuff. We're going to have another one for our chest pathology, right, to make sure we don't miss anything. And then look at the heart and great vessels. So, generally, plain radiograph, chest x-ray is going to be the initial study for almost every kind of chest pathology, okay? So if in the slides you get to the disorders and you just see something in blue for the study of choice, right, and you see nothing in yellow, it's because I'm laying it out right now. Unless I tell you otherwise in the slides, chest x-ray is the initial study for almost all chest pathology unless I have it specifically labeled out. Why is that? Because we don't know what's going on. So whenever somebody comes in with shortness of breath, chest pain, difficulty breathing, any of those kinds of issues, even if we have an idea, even if we're like, hey, I'm pretty sure this is a pneumothorax because my physical exam says this, I'm pretty sure this is a pulmonary embolism, we'll get to that stuff, right? The initial study is always going to be chest x-ray because what if it's not that thing you think it is? And we want to make sure everything is okay, right? We just want to get a whole picture of the chest, see what the heart looks like, see what the lungs look like, and it's super quick and happens in seconds. So chest x-ray is almost always going to be your initial study. For what? There's all my symptoms. Shortness of breath, chest pain, cough, hemoptysis, unexplained fever, unexplained weight loss. Why unexplained fever and weight loss? What am I looking for there? Cancer, right? Good. Let's say the symptoms aren't that bad, but you have physical exam findings, hypoxemia or abnormal lung sounds. We're going to get a chest x-ray. Why are you wheezing? Why do you have rales? Why do you have bronchi? Why are you sounding at 90 instead of 94 or 95 at least? What's going on? We're going to get a chest x-ray. All right? Pre-op general anesthesia. Pre-op chest x-rays are very, very common. More common as you get older, 40 plus. Some surgeons will want them beforehand. It's primarily just to make sure that everything is healthy in the lungs. There's nothing crazy going on in there. There's no goombas, no pneumothoraces, anything like that before they do the anesthesia. Because if the lungs aren't healthy, that patient can have a hard time waking up from the anesthesia, and they're just evaluating that to make sure everything's okay. Or have an idea what complications they could end up with, like if the patient has COPD, they want to know that prior to, how bad is it prior to doing the anesthesia. And then follow up on procedures and pathology. So one of the things you guys will do a lot is when you get to phase 2, and for those of you that aren't working in MTFs in like a family health clinic, if you go into like any type of specialty that involves like rounds or inpatient wards or anything like that, tube and line placement. Whenever you put an NG tube in, right, you get an x-ray to make sure it's where it's supposed to be. When you put an OG tube in, whenever you put a central line in, the lines have a very mildly radio-opaque material in the tubes, intentionally designed to allow you to see exactly where they're at in the trachea, in the stomach, wherever you're trying to go with it to make sure it's placed properly. Chest x-rays are done for that often. Pacemaker assessment, self-explanatory. After lung biopsy, self-explanatory. We want to make sure we didn't cause any damage by getting that lung biopsy. What can we see on chest x-rays? Look at all these things. All right? I'm not going to read them all because we're going to go over a lot of them. All right? But we can find all of this stuff. The valvular stenosis calcifications, if it's really far gone, but what we can see, which we'll learn when we get there, is the sequela from the disease. Do we have an enlarged aorta? Do we have an enlarged left atrium because of the valvular stenosis? So it'll be on your differential based off of that. But the calcifications sometimes, but not always. But those are all the things we're going to look at. Just a quick reminder, talked about in the first block a little bit, how a chest x-ray is done. It's rarely done lying down. There's just the picture. It's just showing you the difference between AP and PA. 90% of your chest x-rays are going to be PA. Okay? 90% of them are going to be PA. If I give you an AP chest x-ray, I will tell you on the test that it's an AP chest x-ray. Okay? It'll either be labeled on the image, AP, or it will be said in the vignette you ordered an AP chest x-ray. And the reason for that is this, right? The AP chest x-ray is going to make that heart more magnified. In this block, we're going to learn how to distinguish what is cardiomegaly, right? What is the definition of an enlarged heart? Well, if I do an AP chest x-ray, by nature of the magnification that we talked about last block, that heart is going to appear larger than it would be if it was normally done for a PA because of the shadowing and the magnification. So if I'm going to give you an AP chest x-ray, I need to tell you. So that way you're looking at it, is that a true cardiomegaly or is it because of the way it's shot? Also, I will not be giving you an AP chest x-ray and asking you to pick out whether or not it's true cardiomegaly or not. I'm just explaining that process, right? Because again, you guys aren't going to be at that level by the exam, nor do I expect you to be, okay? I tell you this and we talk about it because when you're out in clinic and you are ordering or looking at AP chest x-rays, you need to know that it can make it look like cardiomegaly when it's not because of that magnification. Okay? Anatomy. Can I go to the next one? All right, we'll come to it later. Know your anatomy. We're going to skip over this. I have another x-ray that I'm going to break down the anatomy in the areas, but this is one that's good for you to go back. Knowing your anatomy and what we're looking at is super important in the chest. Lateral. Talked about this a little bit last time. It is always a left lateral. We put the left side up against the film, so we call it a left lateral, and that is, again, because the heart is mostly on the left side. We want to get that heart as close to the film as possible to avoid any kind of magnification. So every chest x-ray, every single chest x-ray is a left lateral. Every one. There's no such thing as a right lateral, right? There's no reason to get it, because the only way you're getting a lateral is if the patient can stand up and do it. We don't do them bedside, which is why you only get an AP chest x-ray for those inpatients. Bless you. We only do that if they're able to stand or in the wheelchair or get to the radiology suite and get the lateral picture. So if they can do that, there's really no reason to flip around and do it the inadequate way of a right side. So it's always going to be a left lateral chest X-ray. Here's your slide of the anatomy for a lateral for you to review back to. Again, we're going to get to one here, and I'm going to go over the anatomy on a different one that doesn't have it labeled so we can break it down without the lines. But this would be good for you to study to look at what the anatomy is and what we're looking at. Okay. So, what is an adequate chest X-ray? Before, in MSK in block 1, we were just like, yeah, it looks good. There's enough to kind of see the bones. It was the joint above and below, all that stuff. A chest X-ray has more involved with it because we need to ensure that when we're evaluating the heart, or we're evaluating the rib cage, or we're evaluating the lungs, that everything is the way it's supposed to be so we can make a true evaluation. So we're going to cover a couple of things here. Penetration, inspiratory effort, rotation. We'll fly by magnification because we've already kind of talked about it. Angulation, we'll talk about it a little bit there too. So we're going to go through these things so you guys understand what an appropriate chest X-ray is supposed to look like. So you know if you're making a diagnosis or evaluation with a good image, or if you need them to get another image if possible. So here, I didn't come up with this. I had somebody else come up with this mnemonic. So it kind of works out well if you understand it. So when you're trying to figure out the assessing of a chest X-ray, if you like mnemonics and acronyms, PEER is a good one because you're looking at positioning. Positioning is going to be, is it AP or PA? Is it upright? What's kind of the rotation there? Sorry, the PA or lateral there. Inspiration, we're going to talk about counting the posterior ribs. Did the patient take a deep enough breath in? So when you do a chest X-ray, if anybody's ever had one, for those who haven't, the patient's supposed to take a huge breath in and hold it. And the idea is to inflate the lungs fully throughout the thorax. So you can take a look at all of the lung tissue, take a look at the heart, and see everything. There's a way for you to figure out with the chest X-ray if the patient did a good enough job for you to make an appropriate evaluation on that image, and we're going to look at that. Exposure, that's just going to be the detail of the lungs. Is it too dark or too light? And I will give you tips and tricks of different things on the X-ray to look at to say, is this adequate? Do I see this, this, and this? If I do, then we're good. If not, then we're not, and we'll talk about that. Rotation, we talked about it a little bit. Last block, we talked about the clavicles, but really rotation is going to be looking at those clavicles in that sternoclavicular joint, right? Are they right up against the sternum, or is there a gap and kind of protrusion into the sternum? That's going to be your sign for rotation. You can kind of look at the heart too, but really focus in on the sternum because sometimes the heart can be enlarged and look like it's rotated, but in reality, it's just an enlarged right side of the heart or left side of the heart, and you look at the sternum in that aspect. Okay. We will go look at examples of all these, hitting the intro material first. How do we assess a chest radiograph? These are all of the things that you need to look at every single time. Every single time, right? It's called a cardiac silhouette because that's what it is. It's a game of shadows, right? It's the heart shadow, so cardiac silhouette. Develop your own systematic approach. I'm going to go over mine, just like last block. Come up with your own if you don't like mine. I'm okay with that. But I'm a simple man. I like simple things. I know the alphabet. I won't ever forget this, right? So I go A through I. That link right there for Radiopedia goes over this in detail and kind of talks about it a little bit more. I'll also have the next slide that has everything I'm going to talk about in words for those that just like to read a lot of words, because there are some people who prefer to learn that way. So the first thing I do is I go over the airway. What is the airway? The airway is the trachea, the bronchi, anything involving the airway. Not necessarily some of the lung tissue, I can look at that too, but mainly the primary airway. Is that centered where it needs to be? Then I go over my bones and soft tissue. That's the ribs, the clavicles, the soft tissue around the body, around the neck, all the soft tissue that we see. Then I switch to C for cardiac, which is my heart, my cardiac silhouette. Then I go D for my diaphragm, and we are going to evaluate each of these things. So I'm going to show you kind of what I looked at. Then I go E, looking for effusions or fluid within the lung fields that isn't supposed to be there, and looking at some more extra thoracic soft tissue. So if I didn't cover the soft tissue under B for bones, if you prefer to put E for extra thoracic soft tissue, that's fine too. That kind of covers the area right around your thorax okay with that. That's kind of why I have it in two places. F is for lung field. So this is why I skip over it in the airway. I'm just looking at the trachea and the bronchi because I want to evaluate for the fields, fissures, and foreign bodies within my lungs at the time when I get to F. Fissures we'll briefly talk about. They can be hard to see in normal x-rays. So if you're looking at normal chest x-rays, you're like, I just don't see the fissure. Don't beat your head over it, okay? Fissures are meant to know where they're at in a generality, so when there's abnormalities, you know that's a fissure line if you understand where the lung fissures are. Fissures can be seen quite well on CT because we can just scroll through that fine detail and we'll take a look at some of that. But on x-rays, they can be very difficult to see. Then I go into my great vessels and gastric bubble. Great vessels are going to be above the heart, right? It's going to be my aortic root, the areas coming off of the top of the heart, that whole area. Those are my great vessels, the pulmonary artery, pulmonary vein, all that stuff coming off of the heart. And then the gastric bubble is the air bubble in the stomach, right? So those are both G. Then H, I go to hyla and mediastinum. I know mediastinum doesn't start with H, but the mediastinum is right next to the hyla. Right? And you'll see what we're talking about when we look at the mediastinum, specifically what we're looking for when we get there. And then finally, I is my impression. What is my overall impression of the chest x-ray? Watch out for the shiny toy. You're going to see something on a chest x-ray right away when it pops out, some of these things. Watch out for the shiny toy. Go through your process because more often than not, the shiny toy is the abnormality. The shiny toy is not the reason that it's happening. What's the reason that it's happening? And sometimes you can find that in other areas. This is just the slide of what I just said, but then also more specifically goes into the blue things on the different diagnoses that kind of fit in each area. Don't get hung up on that now. We are going to cover a lot of these throughout the slideshows. This is just all in one area of saying, oh, well, when I look at the cardiac silhouette, that's when I'm looking for cardiomegaly. Okay. When I look at the diaphragm, that's when I could potentially see emphysema or foreign body. Like, don't worry about that now. We're going to go through each of these and show where they're at. But it's a good reference slide when you kind of go back going, what would I normally see and in what area of my process? Okay. Let's draw some pictures and talk about this guy. This is the one that I like the most. So, airway. Right? Trachea. This tube. Whoa, I did it again. I love this system. There we go. Okay. So, why does it do it when I do it on the picture? I can draw here. Here. Okay. So, trachea. Just gotta be careful where I draw, I guess. So, look at the air tube that's coming down here. What the heck?
It's going on the critique.
I'm just gonna go for it. I'll forward it to MCOE. I didn't fill the podium. Okay, so that area there, that is the trachea. That is not the esophagus. Okay? The esophagus is not air-filled. The esophagus is closed until you eat or drink, and then it opens. When I take a breath in, I'm filling the trachea with air, not the esophagus, so don't get that confused. So that's my airway. I'm looking at the trachea. I'm also looking to see, is it midline? How do I know? I have the spinous processes right down the center. Don't go high on the x-ray, okay. I have the spinous processes right down the center. They should be sitting pretty center in that opening of that trachea, right? That tells me it's where it's supposed to be. Now, don't get too hung up if it's like just a little bit to the left, a little bit to the right. It's when it's like all the way, like right up against the edge of the trachea, where the trachea is not anywhere over those spinous processes that you're like, what's going on? Why is that airway moved? Okay? B for bones and soft tissue. I am looking at every single bone and going through it and following it through. Now, I recognize, I'll just go ahead and play until I get to later. Now, I recognize that on an exam, you're like, how the heck am I going to go through and evaluate every single one of these bones and all of this? Well, if you read the question and the answer is all the way, you may not have to, right? I design it in that way because if you just try to interpret the entire x-ray, there is not enough time in a 75-minute exam for you guys to go through and interpret 32 x-rays, right? There's just not. from start to finish. So, read the question, read the answers. The odds are you don't have to go through your systematic process for every question of the test. But in real life, you need to, but you'll have more time to do that, okay? So, looking at all the ribs, looking at the spine, and we'll go over kind of what we're supposed to see here in a little bit, but looking at all of that, all right? Making sure there's no fractures, making sure everything's where it's supposed to be, there's no dislocations, understanding where the scapulas go, because sometimes the scapulas can come into the lung fields here. We'll talk about that in the pneumothorax section. So after I do that, I go over my cardiac area, right? What is that? That's the heart. Pay very close attention to how this shapes out, and I'll do it on both sides so you guys can see it on both sides. I come down, this first bulge is my aortic knob or aortic root. You'll hear me use those interchangeably just because for this course it's just easier just to do that. Aortic knob or aortic root is that first bulge. Kind of comes out here from the spine. I'm using the spine, and that's my first bulge. Second one is really, it says pulmonary artery, but it's really pulmonary vasculature, right? This is the pulmonary artery or pulmonary vasculature. So the artery is here, the pulmonary vein is here, right? It's where the blood is going out to the lungs, coming back into the heart. They're all sitting in this area. The pulmonary vasculature is the second bulge. So bulge 1, aortic knob or root. Bulge 2, pulmonary vasculature or artery. Okay? Bulge 3, not the hilum. Bulge 3, left atrium. Left atrium is bulge 3. Okay? And then below it is the left ventricle. Left ventricle is the largest part of the heart we see. That's the one that pushes the blood out to the rest of the body. Now, when I further go over my cardiac silhouette and I look at it, this bulge on the right side, this is not the right ventricle. It often gets confused because left ventricle is here, and sometimes it's even lower here, right? But left ventricle is here, so this must be right ventricle. It is the right atrium. Because of the way the heart technically sits, the way it's rotated and kind of curved down, right? The right ventricle actually sits right behind the spine in the left ventricle. So we can't see it on this picture. We can't see it because it sits right in here. And the spine is more dense than the heart. So the spine hides the right ventricle from us. So if, when we get there, you start looking at things, you see enlargement on this side of the chest x-ray, on this part of the heart, that is a right atrial enlargement, not a right ventricle enlargement. We cannot see a right ventricle on a PA chest x-ray. Does that make sense? This is where I get like knowing the anatomy and how things sit is super, super important. Because sometimes that bulge will be a little bit lower just based off of the patient and how their heart is, and it's easy to be like, oh, it's right across from the ventricle, it's the right ventricle. It is never the right ventricle. It is the right atrium. Okay. The diaphragm, so I did A, B, C, so now D is my diaphragm. That's this guy right here, these semicircles, or the hemicircles, we'll call them, that come right down in here and give a coshiphrenic angle, these pointed areas here. So I should have a nice semicircle coming down and a nice sharp point at the bottom of both of my lung fields. That's my coshiphrenic angles and my diaphragm evaluation. Okay? The right side is usually slightly higher than the left. Why? Liver. Big organ pushing up, right? That's normal. That is absolutely normal for the right one to be slightly higher than the left. Okay? What you're looking for on this one is, do I have the right slightly higher than the left, and really do I have these sharp coshiphrenic angles down here at the tips of the lungs? If your chest x-ray has clipped off the bottom of these coshiphrenic angles, it needs to be redone. Because you can't fully evaluate that without seeing those coshiphrenic angles. Okay? Alright, so the effusions, there's none on this one. Effusions in extrathoracic soft tissue. So effusions, I'd be looking primarily in the lung fields. I kind of do E and F at the same time, because where am I looking for effusions? Usually within the lung fields. So the fact that I'm evaluating all of the lung tissue. Now, let's take a look at the lung tissue. All of these grayish lines that are coming out, what are those? What do we think those are? So I got terminal bronchioles. Yeah? They're not. They are the vasculature, right? Why? What are bronchioles filled with? Air. Air is black on X-ray. These are grayish. That's fluid. So, you're not 100% wrong on saying the bronchioles though, because in the lungs, the bronchioles match up with the vasculature throughout the lung fields. So where there's vasculature, there are bronchioles. The problem is we can't see the bronchioles because the radiation is going straight through it, and what we're seeing is the vasculature. Okay, so whenever I say lung markings are these grayish lines that are going out that are the vasculature. This is the blood flow that is going out to the lungs, okay? Why do you notice here, and it's hard, so you gotta kind of look past the numbers, right, and the words, but do you notice how the vasculature is more prominent in the lower third than it is in the upper third? Does that stand out to anybody? And if you're like, maybe, try to look at it from this way. Look at the overall density or brightness of the lower third compared to the lack of density or darkness in the upper third. Yes?
Are you talking about the lung in total?
Just, the lung field in general, right? So the vasculature, but in comparison, look at how much darker it is up top than it is down below, right? Why do you think that is? Gravity, right? Gravity. So the fluid is going down. It's easy for blood to go down to the lower part of the lungs. In order to get to the apices in the upper part of the lungs, the arteries have to actively squeeze it to get it up there because of gravity, and then it falls right back down through our venous system, right? So it doesn't sit in this area as long or as prominent as it does in the lower lungs. That is normal. That is normal. I point that out because we are going to get to a condition to where it looks the same, right? And that's going to hint towards certain disease processes of why does the top look the same as the bottom? That's not how it should be, right? So that is normal. So we should have thicker, more radio-opaque areas of the lungs, or brighter, if you want to do it that way, in the bottom third than in the top third because of gravity. Good. All right, A, B, C, D, E, F. So if you notice here, F fissures, they're here-ish, and like here, like you can't see them. Remember how I told you can't see them? Know the general areas of the fissures, and we'll look at them on other pictures here today, kind of show you where they're at to help remind you where the major fissure is, the minor fissure, the oblique fissure. Know the generalities. They're really hard to see on X-ray on a normal patient. Okay? G, great vessels and gastric bubble. Gastric bubble is right down here. Right? My stomach's down here. This can be right up against the diaphragm. It can be over here. Really what that's meant to show you is, hey, is the gastric bubble below the diaphragm? That's step one, because that's where the stomach should be. If it's above, then we have something called a hiatal hernia, which we'll talk about later. But if it's below, that's where it should be. And then B also lets you know that an area of air in this spot of the abdomen is not concerning, because we expect air to be in the stomach. A lot of times when you're going to look at, when we get to the abdomen, you're going to look for areas of air where it's not supposed to be. That's one of the areas that it is supposed to be there. Okay? Great vessels, again, so focusing in on the aortic knob and kind of up here and looking for my aorta to see if it's enlarged. This is a normal chest x-ray. There's nothing wrong with this one. I will point that out when we get to those abnormals. All right, H is my hilums. It's these areas right in here. The left is hard to see because of the heart. But what the hilum is it's an area of collection of your vessels and your nerves and your airways. And we can we'll see it right there. We'll see it better on the lateral because they line up really nice. It looks like this nice little kind of hole. It's like a pathway for all the airways and the vessels and everything. And then I is impression, which is overall, this is a normal chest x-ray. Okay? The rib counting, I have separate slides for rib counting, so we will go over those individually. That's a lot of work when you're evaluating a chest x-ray. You will get better at it, but that is why I say read the question and the answers first. You won't have to do this on every image. And yes, there will be at least one normal x-ray on the exam again, because that's just as important as pulling out the abnormalities. This is just another slide to kind of show you from a CT standpoint, why is that the right atrium and not the right ventricle, right? So we got an axial slice of the CT. It's showing you how when we do a chest x-ray and the radiation is coming posteriorly, anteriorly, why the spine hides the majority of that right ventricle, where the tricuspid valve is and why that's the right atrium that is protruding out to the side of that chest x-ray on that spine. So right? Remember, the heart doesn't sit nice and pretty like in the anatomy, like in the when you draw a picture when you're a kid, like, oh, no heart, no. It's rotated and kind of in, off to the left a little bit. And so this is always right atrium. Lungs and heart. So, a correctly exposed film. There are a couple of things we should be seeing here. Give you this and we'll go into it a little more. So, we just saw the lung fields and saw the beautiful lung markings, right? We should see that, okay? I should not have dark, pitch black in any of this lung area. If it's burnt out to where I have a big black circle, then this is probably overexposed and it's not gonna be good. I gotta be able to see the lung tissue. Gotta be able to see the vasculature. On the flip side, if it's underexposed, right? It's underexposed, these vasculature marks are going to be more prominent, right? Because I gave less radiation, so it didn't push through, so it pops out. So how do I tell that? That's where the spine comes into play. You should be able to clearly see the outline of the vertebrae over the shadow of the heart of each one. If this is a bright white pole or stick, whatever you want to call it, and you can't make out the vertebrae, then it's underexposed. They didn't give enough radiation. Which means now when I'm looking at my vasculature, it's kind of hard for me to tell whether or not that's normal vasculature or if there's actually some up here that shouldn't be there, which we'll get into with the abnormalities. But the key thing is exposure. Do I have nice gray lung fields without anything that is jet black? And can I see the individual vertebrae of the spine going through the heart? I'll tell you as we go through the lectures, there are going to be some inadequate chest x-rays that are in there, but only primarily because they make some of the abnormalities stand out better, and I'm not focusing on the adequacy, I'm focusing on you seeing what the abnormality looks like before giving you just a regular chest x-ray, but I'll point those out. So, this is everything that I just said on that picture, right? Overexposure causes the dark image, think burnt or overdone. Right? Underexposure causes a whiter image. It emphasizes the lung markings a lot more than it should. And you should be able to, in normal exposure, you should be able to have the peripheral 1/3 of the image with the vasculature, thoracic vertebrae, and hemidiaphragms visible behind the cardiac silhouette. This is what I'm talking about. Yes, they're extreme, right? But they're extreme to show you kind of what I'm pointing out here. Cannot, come on. I can't do anything with that, right? This is worthless. But how would I know that this is worthless? I can see all my lung markings. Remember how we talked about the lung markings below and above? Boy, that looks like almost the same density up and down. I can really see these guys up here, more so than I did on the normal. Well, look, I can't see my spine. This is underexposed. I need to be able to see the vertebrae through that heart area. So that's going to be your tip and trick for exposure or penetration, right? Is it quality or not? Questions on that one? Okay. Full inspiratory effort, okay? Focus on the full inspiratory effort. Don't worry too much about the expiratory films. You rarely ever will order them. Almost never, okay? But if you do, then you know you ordered them, so you don't have to, know what proper inspiratory effort is going to be. And the key thing for that is the diaphragm level at the 10th rib, in reality for this course, minimum 8. You need a minimum of 8 full posterior ribs to have adequate inspiration. Okay? Right? It's not a hard cutoff, it's the minimum for it to be adequate. We like 10 to 11. But in order to do that, you gotta know how to count ribs. The key thing with that is it allows visualization of all the intrathoracic structures and the costophonic angles can be visible. I need them to take that big, deep breath in, all right? Here's why. Now, I recognize this is an expiratory film, but I'm showing you this to show what happens if they don't get at least 8 ribs of inspiration. Primarily, I want you to look at my heart, look at the size of the heart. On my inspiratory film, I have my heart. On my expiratory film, or my inadequate inspiration, would you say there's a size difference? There's not. It looks like it on the picture because what's happening? When the patient doesn't take a deep enough breath in, that diaphragm doesn't get pulled down. So the diaphragm is now pushing up on our cardiac area and our heart and causing it to look enlarged because it's squished from the pressure of the diaphragm. Which means if I got this, I know it says expiratory, but this film on the right, I would diagnose cardiomegaly. But the patient doesn't actually have cardiomegaly when they get a proper inspiration. So you can see how a lack of inspiration can cause you to misdiagnose a patient on something that they don't have. So you've got to get at least 8 full posterior ribs on all of your x-rays. We're going to go over how to count those here in a second. Okay, I have better pictures to count them on. So just give you an example of why that has to happen, right? Here's another one on a pediatric. Again, I know it says expiratory, it is, and mainly the reason I'm using expiratory films is there's not a whole lot of inadequate inspiration films out there because they usually don't make it to the studies and stuff because when providers see it, or usually the x-ray techs see it, they just automatically get another one. They're like, sir, ma'am, I really need you to take that big deep breath in. And so a lot of the actual poor inspiration don't ever make it across to you, but you have to know what that is just in case it does, especially if you're in the field and you don't have like a QC system with the RAD techs and stuff and it just comes off to you, right? But again, same pediatric patients, look at the difference in the width of the heart when they don't get that full inspiration and kind of what it does to that whole mediastinum area. All right, questions on inspiration. Minimum 8 ribs, prefer 10 to 11, but minimum 8 posterior ribs. Okay. Let's look at our posterior ribs. There are 2 sets of ribs here, right? We have our posterior and our anterior. Now the ones that are numbered here, bless you, okay? The ones that are numbered here, boy, they look like they're anterior because they look like they're right in the front. And I know the picture is shot this way, so I know the radiation comes in the back and comes out there. So this would be closer to the film. And these guys look like that they're closer to the film, so they look like they're the anterior ribs, but they're not, right? Understand our anatomy. Your posterior ribs are the ones that are more horizontal. Why? Because when I stand here, my posterior ribs are more horizontal, right? So that's your posterior ones. The ones you see in the background, we'll get to the next one, that come down like this, those are your anterior ribs. Your anterior ribs have the big sloping area. Again, why? Well, let's think about it. If I'm standing this way, I have my posterior ribs are horizontal, and then what happens anteriorly? They start to curve around, right? And it's the game of shadows. The ribs curve and come in up to the sternum, right? So it's a different kind of shape when we're getting that image. On top of that, where are all these ribs connecting to?
Vertebrae.
Right? They're connected to the vertebrae because our posterior ribs connect directly to the vertebrae. Where do the anterior ribs connect to? Ah, where do the anterior ribs connect to? The cartilage. Is cartilage well seen on x-ray? It's not. So you can't draw that anterior rib connection to the cartilage. Look at kind of how they just kind of disappear. They just kind of stop. They don't go all the way into the central area because they connect to the cartilage, which connects to the sternum, right? So when you see the ribs that are connecting to the vertebrae directly, those are your posterior ribs. Okay? Now, how do I count these? Well, look at this. Look at 1 and 2. Look at how overlapped they are for my posterior ribs. That is a common counting error. Those things can be almost on top of each other. And you're like, where is 1 and 2? Where is 3? What do I do? Right? So I use my anterior ribs to help me count the start of my posterior ribs. And here's why. Okay? Look at my anterior ribs. Look at how they have that steep downward rotation and how they just kind of end like we just talked about, right? So those are more separated. Those stand out more. So when I go back to my posterior rib counting, I like to find rib number 1 anterior, because to me that stands out more than anything, and it's right here. So when I see it, I trace it up and go 1, here's number 2, 2, here's number 3, 3. And then once I get to 3, because again, the anterior and the posterior rib are connected, right? So it's anterior here, and then boom, it turns into posterior. Anterior turns into posterior. Anterior turns into posterior, right? So if I count my posterior ribs by starting with anterior and going, okay, there's 1, there's 2, and at 3, I stop because 3 is clearly delineated from 1 and 2. And on almost every chest x-ray, 3 will have that gap. So then once you get to 3, now I can go, okay, that's 3. Now I don't need to do that anymore, right? Because I can clearly see the posterior 3. Now I can count from there and I can go 4, 5, 6, 7, 8, 9, 10. Does that track in that aspect, right? I find it easier to count ribs, even if I'm going posterior, to start with the anterior because this 1 and 2 will overlap on a lot of x-rays and it can be hard to pull out. And if you try to, you may end up thinking that's just 1, and then you end up thinking 3 is 2, 4 is 3, so on and so forth. So if you count it that way and trace it up, you should be able to get the right number. Another thing with the ribs, right? So 1, 2, 3, 4, 5. Look where my 5th anterior rib is. Like it goes down. It goes down there. Okay, so you're not going to see all those anteriors, which is why adequate inspiration is 8 posterior ribs, not anterior ribs. Okay, and it needs the whole rib. All right, if my diaphragm is sitting here, that is not adequate inspiration. I don't have the full 8th rib. I need to see it all the way down to the wall of the thorax. If I'm sitting here, I would really like 10, but by our definition, that's good enough. I need to be able to see the rib come all the way down to the thorax. Okay? There's another picture for the anteriors in that aspect. Questions on rib counting? All right, take 10. We'll see you at the top of the hour.
It's crazy. And then our medicine like that is like totally different.
I mean, to be fair.
You should do that. Levi's cards.
Yeah, we are not good at this game.
You get figured out. Yeah, you know, like
I mean, Marlins, but they've been trashed since 03.
Oh, they've been trashed since 03, yeah.
So it's like,
And I'm not a big fan of that.
and also when they changed the logo from the Florida Marlins to the Miami Marlins, it just went downhill even quicker. So it's like,
Fair enough.
yeah.
Exciting time here for baseball.
Yeah, exactly.
I tried. It was like,
That's good because I don't, and also I didn't put track of the flyer because if you saw the conversation I have to just be honest. So I have to say something. I can say something else. Can you help me to set up that on my iPad? Because my phone battery died. So I get but we like to have a story. I just want to make sure.
Yes. I don't know who our trios are. We can make our trio.
Quinn left. Yeah.
We'll make it.
The Bears aren't looking too bad.
We got a bye week this week too.
Oh, that's an early bye. That's a real early bye.
But with the way the first 2 weeks went, the new coaching regime, and then the way that they trounced the Cowboys, and they got really I think a team-defining, gritty against the Raiders, I think it's the perfect time
Yeah.
for them to like use that, figure it out, put more game plans together, right? Because then we have, I think, Monday Night Football next week against the Redskins, or sorry, Commanders.
doesn't matter.
little bit of a revenge game there.
Yeah.
And then if you look at the schedule, realistically, we could end up in the next 4 weeks, like realistically, or 5 weeks, looking at like what is like 6-3 because they're not against great teams, especially Jake Daniels in that.
Yeah.
But I'm still confident that we can beat them because we should beat them the year prior. But it's that hill. So we could end up 6-3 after the next 4 or 5 weeks before we get to the hard part.
Yeah.
So we still got to face like Baltimore.
Yeah, but I think about Baltimore is
How long Mark's gonna be on?
that, and like they're not looking like themselves. And if Derrick Henry keeps dropping balls in like crucial moments, then it don't matter.
I was studying when all that was going on. I actually wanted to go one time. That's when I took it.
Yeah. Sounds like you do
Probably should.
That guy's so much. You know they're playing Sweet Carolina, so we have one up in Ohio.
All right, let's take our seats. Warm up our coffee. I know it's dark in here. This guy's talking about ribs. It's Texas, right? Where they've been thinking about is baby back in barbecue. I get it. Do that. Do that real quick. Hey, next time you guys go out to a barbecue place, ask them for posterior ribs instead of anterior. See what they do. Like I prefer the ones that are more horizontal instead of curved. Right? Okay. So before we jump in, I saw this the other day, and some of you may have already seen it, but it reminded me of IPAP and studying, and so I figured I'd start with a little comment relief of probably what you guys are going through before every exam. I have to play the audio on my phone because it's my COE, you know, I think YouTube. So I'm gonna time it at the same time. Give me a sec.
This video is sponsored by Keats. More about them at the end of the sketch. How do you throw a freaking grenade thing? Oh, hey, there's a guy right there. Shoot that guy. Yeah, you know, we can just jump over. Okay, he killed us. We're dead. Yeah, we are not good at this game. We're really not good at games at all anymore. Oh, hey, damn it, we have that deadline at 5 p.m. for that project thing. Oh my God, that's right. We have to get that done today. I'm gonna go ahead and turn up the stress levels in here to reflect that. Ah, okay. I know, that's fair. It is a big project. It is a big project. I deserve that. Okay.
No.
Hey, here we go. Okay, here we go. Time to get this done. Oh yeah, we got this for sure, my man body. By the way, we gotta focus, okay? There's none of that going down internet rabbit holes thing that we do, okay? Abso-freaking-lutely. Time is of the essence. How deep do rabbit holes go, though, you think? Well, like actual rabbit holes? I don't know. I can look that up. Yeah, definitely look that up real quick. I'm kind of curious. Oh, as deep as 10, 15 feet. 10 to 15 feet? Holy crap! Look at this. They can span almost 150 feet. They must have like a whole network of tunnels that. Wait! What? Do you have me going down a rabbit hole right now? now? Oh, you know what? Yeah, I do. Okay, let's crank up the stress in here a little bit.
Okay, yep, running out of time. Here we go.
Here we go. I'm cranking up the focus. Where does the expression rabbit hole even come from, you think? That's so specific.
I mean, I'm thinking it's probably Alice in Wonderland, right? Let me look that up.
Yeah, look that up real quick. Okay, so it looks like, wait, no.
What?
You're making me go down a rabbit hole.
I'll be honest, I didn't even realize I was doing it, but I
was gonna go ahead and crank up the stratus in here.
I don't know if the extra stress is helping very much.
It might be. Okay, here we go. No more rabbit holes, no more rabbit holes.
Yeah,
Let me just say I know you, and I think you're probably about to put me on some rabbit hole. So let's just not do that, okay?
Oh yeah, for sure. We're on the same page.
No more rabbit holes. No rabbit hole. That's kind of a cool beat. Rabbit hole. What? Rabbit hole.
Yup.
Oh, rabbit hole. I feel like we can be a decent music producer if we put our me to it. You know, I thought that too, but how do you even get started on that career path?
There's gotta be some online classes. Look that up, will ya?
Yeah, like online music production classes, I guess.
Those are probably good search terms.
Oh, so it looks like there's actually some available.
No, wait,
Oh,
no!
my bad. Stress levels up.
Yeah, you think you're just making my chest tighten up at this point.
Yeah, let's use that. I feel like we're at a good level of stress now. Let's just please be productive now, okay?
Should we check out some of those productivity YouTubers for inspiration?
No, we're just gonna focus and be productive.
Okay,
You got it?
I'm ready. Productivity, here we go.
Okay. Rabbit hole. Wait, what are we doing? This is not the task.
It's a task.
It's the wrong one.
We're being productive, kind of.
Productive procrastination is still procrastination.
Whoa, that is deep. You just blew me.
Don't phrase that like that. Increasing stress levels!
Hey, buddy. You paralyzed?
Mm-hmm.
Yeah, that may have been too much stress. Oh, you know what? I just had an idea.
You did?
You know, technically, we could ask for a little extension. You know, just say the day got away from us, ask for a couple of extra hours.
That could work. I mean, the person we're submitting to is pretty reasonable. Let me just type that up.
We want
Sorry,
extended
it will
test.
be a couple of hours late.
Send. That's good.
Okay, so we just stand by. We wait. Oh, they already answered.
Amazing.
Oh, amazing. They said it's fine. They give us another couple of hours. It's totally fine.
Let's do this.
Oh my God, that is such a relief. Okay, let's get this done now. Time to be productive.
You listen to me, my man. We're about to bring this project home.
Rabbit hole. Wait, no.
We're gonna bump this stress up to critical, I think. Hi there. Hello, it's me. I'm the
Alright. So don't do that tonight, no rabbit holes, alright? Get ready for Clean Lab tomorrow. Clean Lab. I think we've all been there. Alright. All that to jump back into this. No. So, questions about counting ribs? No? Okay. So, rotation, we're going to briefly cover this again because we hit that in block 1, right? So the rotation again, watch that sternoclavicular joint, watch the spinous processes. We've seen this slide from before. Don't get hung up on the A, P, and PA. I don't care which way it's rotated, okay? I need you guys to pull out rotation, because rotation means that it's an inadequate image, right? I am not gonna make you be like, hey, is it rotated to the left, is it rotated to the right? For your level here in this, I'm not worried about that. I need you to know that it's rotated. So, again, review from block 1, okay? So what you're looking at, we talked about the trachea, is you're making sure that the spinous processes are sitting right in the center of the trachea. Again, that's the trachea, not the esophagus, okay? And then you're viewing the clavicles sitting right up against the sternum, equidistance apart from where they should be. That is your normal. When you have rotation here on this one, and you have a large gap, and you have, well, no gap, I have nowhere to draw on that one, that's gonna be your rotation. That's gonna be important when we get into chest x-rays, because if you end up having more right atrium on this side like we have here than we see on most images, right? The question is that an enlarged right atrium, or is that just due to my rotation? Right? Because if the patient is rotated, it's gonna project one part of the heart, the right atrium, the left ventricle, depending which way, more so than the other one, bless you. So when you see an enlarged right atrium or an enlarged left ventricle, your next step should be, let me look at the sternoclavicular area, let me look at my clavicles, look at the spinous processes within the trachea, and make sure this image is not rotated before I recognize that as an actual abnormality. Does that follow? Right? Magnification, here it is again. We covered this last block, we covered it again. If you have questions about it, let me know on the break. But just think shadow puppets, and I kind of did that with my flashlight in my hand last block as well. But it is especially important in this one. Now, I had a really good question, which we haven't gotten to yet. Okay? Remember, left is right, right is left. So, but I'm telling you guys that the chest x-ray is done this way, right? So my left side, where my heart is on this side, but yet it's on the opposite side of the chest x-ray. How is that possible? Because the radiology tech flips it for you. This is the standard. Do not, if they shoot it AP, then guess what they're not doing? They don't have to flip it for you because it's already done this way, right? Do not let the positioning confuse you on which way the image is supposed to project. This is the standard, okay? This is the standard. They will always be flipped for you regardless of how the chest x-ray was shot. On top of that, they should have a marker, which they put in here, right, to tell you left and right. But either way, if there's no marker there on the exam, it's not a trick, right? They shot your right is their left, your left is their right. I think I know what you might be about to ask. Go ahead.
Go ahead.
No, go ahead.
What am I gonna ask?
About sinus and versus?
Oh, no.
Oh, okay, go ahead.
Is this an international standard?
That's a good question. I don't know that answer. I would think so, but I don't know. Yeah, that's good. So I always get the one person, I always get, like, your timing was like beautiful, because right at this time, I always get the one student who's like, what about patients with sinus and bursitis? Have you guys heard of that? You guys know what that is? Everything's on the opposite side of their body. All of their organs, right? Yes, that's a thing. I'm not giving you a sinus and bursitis patient on the exam, right? Yes, that is the thing. What that basically is, sinus and bursitis is just a patient whose all their organs are on the opposite side of the body. So the heart is more projected on the right side, the liver is on the left side, the spleen, like everything is just flipped. Don't know why. Way smarter people than me probably know why. I don't. But your timing is incredible, so I thought I was going to do that. But no, I don't know if that's an international standard or not. I'll have to look into that and find out. I know definitely here in the United States that is the standard of care. So I will not be giving you a sinus and bursitis patient, so I'm not going to mess with that and be like, aha, I got you. No. All right, so magnification. FYI slide, not going to spend a whole lot of time on it in this one here, but this is showing you the PA view. Erect means standing, supine means lying down. The biggest way is the parameters of how the patients are going to be positioned on this chart for you guys here to understand how the x-rays are being done. I'm not testing you on this though. Angulation. The x-rays for chest x-rays are going to be horizontal, straight on horizontal. There are certain cases where we angle that to, remember we talked about the clavicle last block, right? Well, we talked about it in terms of the clavicle. To project that clavicle above the rib cage, to be able to get a really good view of it so it's not kind of hiding. In this block, the concept is the same, but now instead of projecting that clavicle above the rib cage and look at the clavicle, which we'll still look at, right, because it's bony, we're going to have to evaluate it, we're doing it to move the clavicle out of the apices of the lungs to further evaluate some abnormalities that might be sitting there hidden by the clavicle. Primarily, usually cavities, usually tuberculosis concern, because it likes to live in the apices of the lungs, and that's why we would do some of these. So what that's called the lordotic view. There's two ways to do this. One, really bad image, but it's old. You can have the patient just lean back like this, and they still shoot it horizontal because the projection of the shadows, which, sure, back in the day when we didn't have angulation and stuff, we could do that. But now we just angle the tube, right? And the X-ray tech does that. And the idea is, here's your normal, right? So I got my normal kind of just horizontal beam, my nice little S-shaped clavicles that come into the sternum. And then when I angle upwards, usually about 15 to 20 degrees, I project the clavicles above the rib cage. But now look at what I can see. I can see this entire area, right? And do you notice that circular mass right there. You may not yet, because we haven't gone into looking at this yet. I'm going to erase it, and I'm going to show you on the apical view again how I have this weird kind of nice circular mass that's not the same on the other side, and I don't know what that is. That mass is on the other chest x-ray, but it's hidden right here behind the clavicle. So that's the idea behind that apical view, is like, what is that? I don't know what that is. Is that an abnormality in the lung field? I'm not sure. I gotta get the clavicles out of the way. We do that apical view to be able to get the clavicles out of the way, and we can see that that is a round mass, probably adenocarcinoma. We'll learn that later, just based off of what it looks like and its positioning. You guys will learn that. But that's the idea behind getting those clavicles out of that lung field. You don't have to do it for every patient, right? You only have to do it for the ones that you're concerned at. When you look at the regular x-ray, you're like, I can't really be confident that that's normal. There might be something there. Then you're gonna take that next step and order that apical x-ray to take a look at those lung fields up there. Good? Okay. These are the review slides we talked about, right? Penetration, inspiratory effort, rotation, magnification, angulation. These are for you as you're going through and studying to just kind of see if you got the concepts down in that aspect. We've already talked about, just a few more slides, on the posterior and anterior ribs. Kind of went over all of this already on the picture, it's just here in words. Remember, the posterior ribs are more horizontal and attached to that thoracic vertebral body. The anterior ribs are oriented towards the feet, so they have that sharp downward angle. And they'll attach the sternum, really it's the cartilage, which can't be visible a lot on the x-ray. Which is why when they take a CT scan, we end up with this. So this is that 3D remodeling. We saw some of those in the first block, kind of just showing you what it looks like. This is kind of helping to explain why we can't see those anterior ribs go up and connect to something, because look, they're not missing, it's just cartilage, it's not bone anymore. So the CT 3D reconstruction machine doesn't pick it up as bone to be able to make that model. Here it is laterally, right? So with the chest x-ray, if possible, we are always going to get two views, just like in the first block, right? We're gonna get the PA, we're gonna get the lateral. On your inpatients, or your bedridden patients, or your ER patients, sometimes that lateral is not possible because they have to be able to either stand or sit in a wheelchair to get up to that machine. You cannot do those portable. Lateral chest x-rays portable are trash, right? They don't get good penetration. It doesn't work, so they're not done. And so that's why you only get an AP on the patients who are in the hospital. But if we can, we want two views. Two views are super, super important because with just one view, you only get part of the story. With two views, you get the entire story. Right? I don't know if anybody remembers when that happened. But this is why we need to have two views, because otherwise we think things are happening that are actually not happening. Right? So then you say, well then what is it on the lateral chest x-ray that we can't see on the PA that requires us to get a couple of views? Well, here's what we're going to find. So these are your 5 key areas in a chart form for you on the lateral chest x-ray that we're looking at. A couple of things. We're going to look at the retrosternal clear space and see what that looks like, because think about it, on a PA, if I got my sternum, what's behind it? What's going on behind it? I have no idea, because the sternum is dense and it's taking up all that radiation. I can't see behind the sternum. We're going to look at the hilar region, because it's a lot easier to see that on a lateral chest x-ray when you got the two superimposed on one another. We're going to try to find our fissures. Try to, not always visible on a chest x-ray. We're going to use our thoracic spine to make sure. We're going to talk about what the spine sign looks like when we get there, kind of how the thoracic spine is supposed to look. And we're also going to look at our diaphragm and our costophrenic angles and the space behind our heart. Okay. So here are our blind spots. All of these are areas that we can't see behind on the PA chest x-ray. The yellow circles, okay, is going to be your hilar regions. The blue circle up top is going to be your retrosternal that I just talked about. The red circle is the cardiac space. I can't see anything behind the heart because the heart is dense and it's taking up all that area. There's lung fields behind there, but I can't see them, right? And then your claustrophrenic angles, and we're gonna talk about why you're like, but you circled claustrophrenic angles, how come we can't see those? We're gonna talk about that here on the lateral. Here is the space that it's referring to. So, retrosternal is the lung tissue right behind the sternum. It's gonna be a little bit darker than some of the other areas, but this is now what we get a lateral chest x-ray for. Because I can't see this on my PA because the sternum takes up all the radiation. It's too dense. Retrocardiac space, this dark space right behind the heart. I can't see that on my PA chest x-ray because again, the heart is extra dense and between the heart and the spine, there's lung tissue there, but between those two things, I can't make out that lung tissue. All I'm seeing is spine and heart. So that's why we get a lateral. On top of that, look at what part of the anatomy of the heart we can now see. The right ventricle. Because I took that side view. Where I couldn't see it before because it's sitting right in front of this spine area on the PA, I can now see my right ventricle on my heart. We're looking at the spine and looking at all the vertebrae to be able to see those appropriately. We will learn what happens when the spine, notice how here the spine gets a little bit darker in density as it goes down. It's brighter white here, and then it gets a little bit darker as it goes down. As far as the vertebral bodies, it looks like it's a little more radial. Okay, that's normal. That's normal. We will learn what happens when it doesn't look like that. But understanding that we should have a continuing darkening or more radiolucent area of the vertebral bodies as we go down. It's not because the vertebral bodies are having osteoporosis or anything like that, like we talked about last block. It's because of all the lung tissue here. All that extra air that's in that area causes more radiation to go through, makes it look darker. This is why we don't use thoracic spine x-rays to go, ooh, I think you have osteoporosis. We use that lumbar spine or that hip that we talked about last block because this is supposed to be darker and look more radiolucent because of the lung tissue as you go further down. We're also seeing our posterior claustrophrenic angles, which means, which claustrophrenic angles are these? These are my anterior claustrophrenic angles. Because look at where the posterior is, right? And if the radiation comes in from the back, hits my posterior claustrophrenic angles, and then I have all of this soft tissue absorbing the x-rays and the radiation, by the time I get to the film, none of that radiation is really hitting the film. I can't see my posterior claustrophrenic angles on a PA chest x-ray. What you're seeing is these anterior claustrophrenic angles on the chest x-ray. So if you want, so this is anterior, if you want to see your posterior claustrophrenic angles, you need that lateral film. This will become important later on when we're talking about pleural effusions and fluid and how much fluid are we seeing if we can find it on chest x-ray and what's going on. You see why we do the lateral. You recognize the 5 spaces that we're looking at. The hilar region is not well seen on this one. We'll look at it at another lateral chest x-ray later on. Okay. Talk about some more anatomy, some more heart and great vessels, and kind of what some of these words mean, okay? So hemithorax, one side of the chest, half the thorax. Claustrophrenic angles, we've talked about that already. It's basically involving or draining the ribs or the diaphragm, claustrophrenic. Cephalization is concentration of anatomy towards the head, but we're going to use cephalization in this course for an abnormality that we're going to talk about of the vasculature. But technically the definition of the term is looking at any anatomy that goes towards the head, and you'll see why we describe cephalization the way we do. Covering normal cardiac anatomy, plain film, CT, MRI, abnormal cardiac appearance. So here's where we start to talk about cardiomegaly, congestive heart failure, pneumopericardium, some of these abnormalities that are getting in there. Here is your normal chest x-ray. This is a good one that is not labeled, that you can use to make sure you need to know your anatomy. Okay? I have it labeled and here in the picture on the side of it as well. But the biggest thing, right, is going to be your aortic root, your pulmonary vasculature, your left atrium, left ventricle. This is your right atrium here. Okay, knowing that area, looking, finding my claustrophrenic angles. Okay, Not gonna go over all the bones and soft tissue in that, but just kind of showing you areas you gotta make sure you hit. Looking at my vasculature, seeing that it's darker up here as opposed to lighter down there, right? Kind of, you can see that if you compare the two circles. And the more you look at it, the easier this will be for you guys to kind of pull out and see. Those are all normal areas. Looking at my trachea, my spinous processes, that's one way for rotation. The other thing, checking out my sternoclavicular, they look pretty good. That's another way for rotation. Just going through the anatomy and understanding what we're looking at, okay? Remember, the radioopaque lines in the pulmonary vasculature or the lung markings is the vessels. It's not the bronchioles. Even though they run together, that's not what we're visualizing. We're visualizing the vasculature. And there's that example. Now, on this CT, you can see the bronchioles on the left side. On the right side, you can't, right? This is where you can't, this is a normal thing here. You cannot see the bronchioles that well, even on CT. However, if there is a bunch of inflammation or fluid surrounding those airways, then the airways become prominent, the bronchioles become prominent. So what this is there's inflammation and scarring on this side, so that's why I can see the bronchioles. Not because the bronchioles like, oh, I can see it. It's because there's so much going on around the outside, it basically encircles it and makes it stand out more, right? And we're gonna see that with some of this congestive heart failure patients of how we'll be able to see the bronchioles on chest x-ray, but it's not because there's something wrong with the bronchioles, it's because there's fluid around the bronchioles that make it stand out. Another slide for you to look at and understand where the fissures are, right? So, horizontal fissure, oblique, or you go major or minor, whatever we're doing. I'm not gonna make you pull out fissures on an x-ray, right? I'm not gonna make you do that, but understanding where they're at, so as you see some of the abnormalities later, when there's fluid in a fissure, you can pull that out and be like, hey, that's fluid in the fissure, because if I know where the fissure's at, I know the shape of it, and there's fluid there, and we'll see some pictures with that. Another one to break down and for you guys to look at and practice your anatomy with. You notice a trend with this first slide deck. Know your normal anatomy, know what a good chest x-ray looks like, all right? It will help you a lot going forward. Here's a lateral with it drawn out again, and then right next to it, one without the markings. I didn't draw it on the last one, but there's your hilum, right? Really, it's that little dark radioopaque circle right there. That is the hilum and the hilum area on the lateral, and it stands out more on that because both the right and left hilum are basically superimposed on each other, right? Sometimes they're a little off, but when you go to the lateral, they get superimposed on each other, and you got that nice pathway of where the vessels and the nerves and the airway and the hilum all kind of go. So that's normal area. What else is on here? Yeah, that's pretty much it. The rest of it is normal. Here's my gastric bubble, right? On my lateral, which you can also see. This is part of the diaphragm. There's two diaphragms, right? Two sides of the diaphragm. It's one thing, but when you put it to the side, you have a right and a left. And they're slightly off a little bit, but that's okay. That's normal. And if we need to look at the vasculature, right? Because right now, everything we've looked at, let's go back here. Where's the blood? Where's the heart tissue? I don't know. Fluid and soft tissue look the same on x-ray, right? When I go back to this one, where's the blood? Where's the heart tissue? No idea. Where's the blood? Where's the aorta? I know where the root is, but I can't tell you what's going on the inside. And so that's where if we need to evaluate the vasculature, we need to evaluate the blood flow, that's where we end up needing the CT with contrast. Okay? The little bright white areas around this aortic root up here, this area up here, that's calcifications of that aorta. That is not contrast, it's calcifications around the edge of the aorta. That'll happen in your long-term hypertension patients, older patients, other processes that you guys will learn about in cardiology. It can calcify your aorta, kind of like the what are we talking about, like bone spurs and stuff like that? Body doesn't like pain and inflammation, so they'll start calcifying things to try to limit it without realizing that it's causing further damage in other areas. So that's what that is right there, but this is all your contrast. And remember, we need the contrast to look at the inner workings of the vasculature and the actual heart. Here's another one. So I have ascending aorta, descending aorta. Okay. This area here is my pulmonary artery. That's my pulmonary artery. Recognize that shape, know that shape. We're going to get to an area of pulmonary embolisms where this is the primary image you need to look at to figure out if they're having a blood clot or having a pulmonary embolism or not. Okay? And then, where am I at here? Superior vena cava is the S. And that is going to be what type of view? What slice is that? Axial, good. And then here's my coronal, here's my sagittal, okay? And you can see the benefit of all the different views. Now remember, we do the CT, and it gets done axially, and then afterwards in post-production, if you will, we'll go through and give you your coronal and sagittal slices. So the nice part about that is now we can see the full aorta come all the way down, right? We can see our left atrium, left ventricle on the coronal here. We can see our right atrium. We can see the left ventricle pushing the blood through up into the main aorta. So you can get a lot of anatomy information when you give the contrast you're doing a study of the chest, right? If you're really concerned about aortic aneurysm, dissection, pulmonary embolism, all these things we're going to talk about in the later blocks. This is kind of showing you how sometimes you can see some of the airways, okay? FYI, I'm not going to have you kind of pull out where it bifurcates on this guy, but this is the trachea, right and left main bronchus. Just showing you when you do those coronal slices how you can really evaluate that airway a lot better as well. Here's a normal MRI of the chest. You will probably never order this. Never ordered one. This is like a specialist order type thing. I don't even know what you would order it for, but more your cardiopulmonary folks are going to order these, probably for some type of mass or something that they can't distinguish even from CT. But chest MRIs are very, very rare. Initial study for chest pathology is going to be the X-ray, and if you need further, it's probably going to be a CT with or without contrast, depending on what we're trying to look for when we get those abnormalities. All right. So, what is, let's label some stuff here. 1, 2, 3, 4, 5, 6, 7, 8, 9. Oh, boo. Here we go. Okay. So, what is number 4? Good, your pulmonary vasculature. All right, cool. What is number 8? Which one? Your anterior costophrenic angles. Good, don't get that confused. It is not posterior. What is 6? Which one? Will that give you time to count? Your 8th posterior rib. Let's count it together. Right? 1, 2, 3, 4, 5, 6, 7, 8th posterior rib. This is one of those pictures to where if you're like, oh yeah, here's 1, here's 2, you can easily get mixed up if you're not using that anterior rib trick I showed you to come up and come around and follow it around. Good. So I guess on that note, what's number 7? Good. 4th anterior rib. Good. What's number 3? Right atrium, not the right ventricle. Okay? And then we'll just, for the sake of time, go through the rest. So number 2 is your left ventricle. Number 5 is your left atrium. Number 1 is the aortic root or the aortic knob. Good. So benefit you when it comes to the pathology and what is abnormal later as we go through stuff. Here's another example of your lateral chest x-ray. Okay? Again, remember now, this is where we see the right ventricle. Biggest thing on this one is we're finding those other areas. So now we got our posterior costophrenic angles, retrosternal space. This one's a little overexposed, if you ask me, a little bit, because my retrosternal space and my retrocardiac space are almost black. Can't really see that lung tissue there. So I would like one with a little bit less radiation to get a true evaluation. You'd be okay asking them to redo this one. I probably would if I had concern for pathology there. If it was just a kind of like I'm doing it just because I don't expect to find anything like a pre-op or something like that, I probably wouldn't. But if you're looking for pathology, I definitely would ask them to redo this one. Okay. So in summary of that, that's what we covered. Okay, we got a few more things to get through here, but that's what we covered in those sections. It's really mostly anatomy. Anatomy and appropriate chest x-rays. Got to understand that in order to find the abnormalities that we'll start talking about probably tomorrow. Or maybe even today. Let's see. So now we're going to go into airway a little bit. Vocabulary. I'm not going to give you vocabulary per se on the test, but you need to know what the words mean, so that way if the words are in the vignette, or in the stem, or in the answers, you understand kind of what we're talking about. So that's why that is there. We're going to cover normal airway anatomy on plain film and CT, and look at all these things that really mostly from plain film. Rarely do we need CT. We are able to diagnose and figure out just from a chest x-ray. And patient symptoms, patient history, right? Whole concept, okay? We can find all of this stuff. Some needs a CT, but a lot of it just needs that chest x-ray. Normal airway anatomy, we covered that already. Really want to hit home. But now the key part of this section is understanding how the lobes of the lung come together. This is another reason we utilize 2 images, a PA and lateral. Because the right lung has 3 lobes. So if I see something here, before looking at this picture, what lobe would you have thought it was in? Right? I don't know, probably lower is be your guess, right? But then you come to realize when you look at this picture that the middle lobe on the PA and the lower lobe overlap. Same thing with the upper lobe and the lower lobe. There is a section of the lung to where they overlap. So if I have a consolidation of fluid or a mass sitting right here, I don't know if that's an upper or lower lobe unless I have my lateral. Because what I can do is compare the area of abnormality with my lateral, and now I know it's upper lobe or lower lobe. Or if it's down here, middle lobe. Okay? So understanding, and this is also where your fissure lines are going to kind of be as well. So understanding, so fissure 1, and then the other fissure kind of like comes down like this way. It's weird. The lateral position of the lobes compared with the PA. So what we use is we use the PA chest x-ray to find what lung, right or left lung, we find an abnormality, and then we use the lateral to tell us what lobe, right? Because which lung am I looking at on this lateral chest x-ray? Anybody know? The left lateral. Which lung am I looking at? Both. They're superimposed on one another, right? So I don't know. So that's why you have to use the PA to figure out what lung is the abnormality in before you go to the lateral to figure out what lobe it is in. Because they're superimposed on one another. Because that's right lung. Look at my left lung. That upper lobe is almost the entire side, the entire thorax. So we have this large area of overlap here That can be upper or lower lobe. So you need to use both. And this is the same lateral picture. It's the same PA picture too. So you gotta understand your lobes and where those areas are, and with the two together, you will be able to, let's say you know it's a pneumonia, right? You look at everything, you look at the symptoms, when we get there you learn it. You look at the symptoms, you look at the chest x-ray, you're like, this is a pneumonia. If you have a PA and a lateral chest x-ray, you can then tell me specifically what lobe that pneumonia is in, if you have both. You can tell me right middle lobe, left lower lobe, by utilizing these two together. Does that make sense on how we can do that? We will see these pictures again, going back to lobes, because pulling stuff out based off of where it's at is going to be important. So just recognize that you need both most of the time. What happens if it's an inpatient and all you have is that AP chest x-ray? No, you don't get a CT. It's not that important of home flow radiation. Later on, I'm going to have a chart in a little bit that's going to show you, we're going to talk about something called a silhouette sign that blocks something up that gives you a most likely, right? And so I will stand up here and tell you, to be definitive of what lobe it is, you need a PA and lateral chest x-ray. To be definitive, you absolutely need that. But in some situations where all you have is a PA or an AP for whatever reason, based off of where your abnormality is and what part of the anatomy it obscures, you can have a most likely guess of what lobe it's going to be in, even without the lateral. And that's where you would say, hey, based off of this, it's probably this. I can't be definitive, but of all the possibilities, this is the most likely. Right? And so we get into that most likely with the information we have presented. Okay. Do not get confused. Don't giggle either. By breast shadows on a chest x-ray. I draw that out to show you, because we haven't seen one like that yet, it is normal to have breast shadow on a chest x-ray. And people will see this line when we get there, and they'll be like, oh, that's probably a pneumothorax because there's that line right there. Or there's something going on because all of a sudden this area is more radio opaque than this area, right? Pay attention to your anatomy. Pay attention to what you're looking at. If it's a female patient, it's likely a breast shadow. So the rest of this is showing you more anatomy in that area. Okay, remember the white lines are vasculature, not bronchi. Here's another normal airway anatomy. I do this in the beginning so we can get to the end and just kind of roll through. We already talked about lateral films. Why do we do the left side? It's to decrease the magnification of the heart, right? What do we get a lateral for? Location, like we just talked about in the lobes. Sometimes you can see one of the fissures on the lateral, and looking for those areas, those hidden areas on that PA that we can't see. It helps us visualize the rest of that lung field. And then I found some x-rays for you that actually show the fissures quite well. So, here and here. All right, so yeah, thickened line on both, on the lateral there. And then the minor fissure is actually this like little kind of thickened line right here. Hard to see, easier to see on the lateral. There and there. You're really gonna notice the fissures when there's abnormalities, especially when there's like something called atelectasis or pneumothoraces. We'll take a look at those things, and those fissures will really stand out there. So understanding how many fissures are in what lung has how many lobes will help you kind of pick out those abnormalities there. More normal airway anatomy, okay? What the white double arrows here are showing you is that the the vertebrae are of equal size, but getting darker as it goes down. Posterior costophrenic angles, okay? These are showing you your diaphragm coming up and across. All right, this is going to be your hilar region, the big white circle. So kind of comparing it to the normal anatomy slide on that one. giving you lots of different normal anatomy, x-rays, and pictures to go through and practice, practice, practice. Okay. This is where we talked about it briefly. We'll talk about when we get into the pneumonia. Having that thoracic spine, this is a better picture, gets darker as we go down. If it's brighter here, then that means there's something obscuring it. There's something else there besides normal lung tissue and air. What is it? Most commonly pneumonia, but it could be of multiple different things. Okay? We call that spine sign because it's a sign on the spine. Right? It's not as radiolucent as we go down. It's more radio opaque. And we'll see what those abnormalities look like. Last few slides of this slideshow is preparing and putting together for you guys this instead of the overlap. To help you pinpoint the locations together. Again, you need both. Study these, know these, understand these, so that way if you need to pull out something that is in a lobe and you need to identify it, you are able to identify which lobe it is based off of the two pictures together. The middle lobe gets the trickiest, right? Because what's all in here? The heart, right? Which is already more radiopaque than the surrounding lung tissue. So you're like, well, how am I going to see that? It can be difficult. But if I have a consolidation or an abnormality sitting in this area, and I don't see anything in the lower area, the lower lobe area, right? Then maybe I'll look deeper into my middle lobe on my lateral and see if I see it. It's using your tools to kind of help you out. But when I see something here, I know my upper lobe ends here on the right side. So if I see something in this region, I know I'm buying middle or lower lobe. So that when I go to my lateral, do I see anything in the lower lobe area? If I do, great, I found it, it's lower lobe. If I don't, then I'm going to look harder right where that heart overlines to see if I can see it there. Got a secret for you. If you have it in here and you don't see it in the lower lobe, whether you see it or not, it's probably in the middle lobe. Because the abnormality's there, right? You can see it on the PA. So when you're trying to decide between the two, focus on really evaluating that lower lobe first and see if you see the abnormality, whether it's fluid, whether it's a mass, whatever it is, and atelectasis, and we'll cover all that. See if you see it there first, and if not, go, yeah, probably middle lobe. Left side. Left side. All right. This is just refreshing your mind on the CTs of how we can have the regular CT. We talked about it briefly last time. You can get this lung window. Look at how much prettier, that's good English. Look at how much more clear the lung tissue is and the vasculature is in this lung window. Again, the patient doesn't get rescanned. It's one scan and it's an algorithm. Bless you. You just hit a button and it changes to this window. You guys will see that in the lab. You're going to get practice kind of toying between the actual windows and scrolling through a CT in the lab for this block. Look at how beautiful the fissures are on a CT. They stand out really, really well. Fissure there. This one's a little bit harder to see, but it's right there. But you can see the fissures really well on a CT, especially in that lung window. Almost there, guys. Just a couple of slides about the hilum and the hilar region. We already talked about it, but it just gives you a picture to kind of show you how the vessels and everything work on those two lungs and where they come together in that region and why it creates, when they're superimposed on each other on the lateral, that nice kind of radiopaque area, that little circle with, radiolucent circle with a radiopaque surrounding, right? Because it's the opening and then the vasculature kind of around it. And that's what makes that kind of pop out and jump out in that hilar region. Typically they are going to be offset just a little bit, which is why we usually use the lateral to evaluate those a little bit better. That was an entire slideshow and almost 2 hours worth of just literally learning and looking at the anatomy of a chest x-ray, what normal is supposed to be so you understand what you're looking at. When I tell you that understanding the anatomy is gonna help you a lot. You will see when we get in there, it will really, really help you because there are certain disease processes that can cause an enlarged left atrium. Which means if you see an enlarged left atrium on the chest x-ray, you probably already narrowed down the things that could be wrong. Same thing with the left ventricle, same thing with the right atrium, same thing with all the other stuff we're gonna talk about in the anatomy. If you understand that, it will help you when we get to what is that disease process. Questions? Yes, ma'am.
So on slide 71,
71. Yeah.
like, is there any certain landmark that like we can identify the left main bronchus? If there's no lines on it, because
The left main bronchus?
yeah, on the left image.
No, it's just kind of really showing you ballpark where it's at. Don't get hung up on trying to pull that out on the lateral chest x-ray. Yeah, it's just kind of showing you where the bronchi are typically going to be, the left main one. I'm not going to have you pull that out. It's just kind of trying to annotate all of the anatomy for you so you kind of understand that this is after the trachea bifurcates. So yeah, don't get hung up on trying to pull out the left main bronchus on the x-ray. Ma'am. So you're talking about looking right here, right? So maybe, right? So I like that you saw that. So then if I saw that, my next step is gonna be, where do my clavicles come in? And they kind of come in fairly similar together, so I would say no on that. That would be your next step. But I like that you saw it and you go, okay, let me take a look and see, is this possibly rotated? What likely is going on here is, what do you think those things are? EKG leads. This is an inpatient. So who knew that likely they were getting the AP chest x-ray, and so this is an AP chest x-ray. They were getting that, and maybe they were just kind of like looking a certain way and kind of rotating a certain way up here, but the chest x-ray is okay because of the sternoclavicular joint. But good eye. What'd you have? So what I was saying was that because if I look just right here, so let's focus here, right? The middle lobe is right over the heart, right? So I know this is an upper lobe picture, but it's because I'm not covering it right now. So the middle lobe is right over the heart. So if I have a consolidation or an abnormality here in the middle lobe, it could be hard to pull out over the heart because it's not as radiolucent as the lung tissue. So when you're trying to figure out, is it middle lobe or lower lobe on the right side, the first thing you're gonna do is on your AP, right, is it in this area? Because if you notice what I just circled there on the lower lobe, it's the same on the middle lobe, right? So then I'm like, okay, is it lower or middle? So what I would say is when you see that and you know it's down there, go to your lateral and focus in on this area first. Do I see my abnormality in this area? If I do, I'm done. Right lower lobe, right? If I don't, then I'm gonna jump into looking deeper into this area because it can be hard to find on the lateral because that heart is sitting there. So that was my trick. Yeah. I had saw another hand before I took his question. Yes, sir.
Yeah, sir. I was just wondering, like, with certain pathologies, so like, so you get a PA on someone, history, physical exam, and you suspect pneumonia. Why do you care, like, what lobe it's in if we're just gonna treat them?
Because you're gonna treat them, right? But what happens if they don't get better? And you wanna know if they're getting, like if they don't get better symptom-wise, and you wanna know if the pneumonia is getting worse, and if it was the right antibiotic, because you're gonna treat based off of what the most likely organism is, but it may not be that. And so, why do you wanna know what lobe it is in? Because you wanna be able to evaluate that. It doesn't change your treatment per se, but what it does is it be able to pull out, for example, hey, this was in the right lower lobe, they didn't get better, they came in for follow-up, we did another x-ray, and now all of a sudden it's in the right lower and the right upper, or and the right middle, right? And it's now usually stays lobular, but what if it moved or got bigger and went into other lobes? And so it's more of a disease tracking thing if they don't improve, than it is designed to like, oh, well, this lobe is this kind of treatment. So, that's kind of why you want to know that. And really, it's less so, I'm using pneumonia now because it's a simple thing that everybody kind of knows what pneumonia is. But in reality, where it's really beneficial is when you end up finding a mass or something and you're able to contact pulmonology, oncology, whatever the case is, or biopsy and be like, hey, it's a mass in the left upper lobe. So they know exactly where to look, what to do, and that's why signifying the lobes are important when you go to the specialist and stuff as well. Not so much for pneumonia, but I just use that as an example because you'll see that more often than you'll see the malignancies. Yeah, good question. What else? All right. See you guys tomorrow morning at 10. Good luck this afternoon. Be nice to each other.